Hello, I'm Amy Barnes and I'm a consultant radiographer at the University Hospitals of Leicester. I'm an advanced practitioner in head and neck imaging and I'm here today to talk to you a little bit about my role. So my career started as a diagnostic radiographer. I extended my practice to become a sonographer and trained in medical ultrasound. Then I had the opportunity to specialise in head and neck ultrasound, and I was trained by a consultant radiologist within our department. And that progressed on to performing ultrasound guided biopsies. Subsequently, I became a clinical lead with 4 other of my colleagues, in particular to try and enhance the service that we were giving for head and neck ultrasound. I became an accredited advanced practitioner, accredited by the Society and College of Radiographers following that post. And then I also took a post with the University of Derby as an associate lecturer, and that is to provide an ultrasound postgraduate certificate course for ultrasound of the neck and intervention as well. And then most recently, this year, I have been promoted and I am now a consultant radiographer. So just to go into some information about my role, my training followed the RCR recommendations for medical and surgical specialties, and it was supported by external study days and workshops. And this is really because there wasn't a higher education institute course that I could go to follow a programme, which is why we've put one in place now. So I work autonomously in performing fine needle aspiration and core biopsy. And as well as the technical aspect of performing the biopsies, there's other things to consider. So we need to consider safety, whether the patient is anticoagulated, and does this need managing prior to the biopsy? So that's always something that we need to consider, because the biopsy is ultrasound guided. Safety aspect of there being other structures in the way is obviously not so important, because we can see the needle tip all the way through the biopsy. We also need to consider the appropriateness of the biopsy and whether this is the right type of procedure for the patient and what we think the pathology might be. So you can see on the screen on the left hand side, that's a fine needle aspiration, and then the top right hand side, that's a core biopsy. And sometimes one is more appropriate than the other. So thyroid cancer is very well diagnosed by fine needle aspiration, and lymphoma is very well diagnosed by core biopsy. However, if there's a lesion on a nerve, then that's very painful to be putting needles into, and we don't want to be doing that at all. So we need to consider what's the best pathway for the diagnosis of that patient. I also have to be able to understand cross-sectional anatomy, because if the lesion has been picked up on an MRI scan, which you can see on the bottom left, a CT scan, which is the middle image, and then a positron emission tomography scan, which is a PET scan on the bottom right hand side. If the lesion's been picked up on there, then I need to be able to correlate it with the ultrasound and then target the lesion for a biopsy. I've taken this knowledge further in the last year, and I'm now training to report cross-sectional imaging for cancer staging scans of the head and neck. As well as the clinical aspect of my role, I have been lucky enough to have lots of opportunities in lots of other ways for patient improvement projects, but also it has allowed us to extend our services. So the straight to test pathway is for thyroid cancer patients, and they can be referred straight from their GP. And if there is the suspicion of a cancer, we would perform the biopsy and we could even go on and arrange the CT scan if necessary, and then the patients are discussed in the MDT with their diagnosis. If there is no suspicion of cancer, then we can write a letter back to the GP and discharge the patient. So that's a really nice, efficient way of using ultrasound and diagnosing thyroid cancers. We've also been able to put post-treatment patients into a more efficient route for having their surveillance scans, and oncologists have seen a huge improvement in the quality and efficiency of patient surveillance. And for that, I developed a form which you can see on the top right, and that's a dedicated imaging form just for those patients, so they get the correct protocoling and the correct scan at the correct time. I've also improved safety around core biopsies. I've been involved in providing a safer surgery checklist as part of a LOCSIP, and that has really improved efficiency during the procedure, because this is now much more dedicated to the procedure that we perform rather than the generic one with a lot of steps that we didn't have to go through. And then there has been endless opportunity to be involved in audit and research as well. So although I'm autonomous, I don't work alone. There's lots of different teams that I work around and that work around me, and this works really well, and I think is a huge part in working as an advanced practitioner, that we can work well within teams, and this is just some of the people that I work with within the department, but then also the referrals that come into us as a head and neck service. And obviously we have our patients, and that's where our care and the reason that we've become advanced practitioners lies. So I had a patient recently that I see regularly as part of their surveillance. And we got chatting last time, and I told her we were doing this presentation, and it was really interesting to see what her experience of my role was. And I think it's clear to see that it's not only what we do and what our knowledge and skills are, but also it's very much how we translate these skills into what we say to patients and how we treat them, and how we explain things. And this member of this patient is actually a member of staff in the department as well. So although she has a wide knowledge of my role, to then become a patient, she saw it in a completely different way, and she was very supportive of what I do, what I've achieved, and is very, like it shows at the bottom, very supportive of the advanced practice role. So for my last slide, I thought I'd just share a little bit of generic feedback. I hope my talk inspired some of you to show that advanced practice is something that is achievable, and something that is of a benefit to not only us as a profession, but to patients and the wider clinical team as well. Thank you.